Welcome to the Foot Health Facts Podcast, powered by the American College of Foot and Ankle Surgeons. I'm your host and a fellow of the college, Dr. Matthew Dairman. Welcome back to part 2 of our heel pain series. I'm here again with our favorite twin doctor dad, Dr. Michael Kelly, and today we're cutting through the clutter to talk about what actually works when it comes to treating heel pain, or in our case specifically, plantar fasciitis. So, welcome back, and let's talk solutions. What's the first thing you typically recommend when someone comes limping in?
Well, first we need to understand why the patient is limping. Is it a foot issue, or are there foot symptoms that could just be manifesting in the foot, but are actually caused by a problem elsewhere, such as the knee, the hip, or the back? And so our first step is taking a history. So that's understanding what your problem is, how long it's been there, where it is, the things you've done, what makes it worse, what makes it better. Doing our actual physical exam, more specifically, where is the location of your pain? What is your overall underlying foot structure? Doing a gait analysis, which is watching patients walk, and oftentimes X-rays play a big role in helping us uh, develop a diagnosis. And so our job is to try to assist in altering those poor mechanics, assisting with any type of structural problems, and helping to modify the activity, are all important aspects of treatment.
So it's about getting to the proper diagnosis, obviously. Do you guys use ultrasound?
We do not specifically
Oh,
in our office. I'm in a hospital-based practice, so we would need to send our patients to the ultrasound department in order to obtain those.
yeah. I use it relatively frequently for heel pain because it helps really differentiate and measure that fascia. So footwear can make or break recovery. What should people actually look for in a good shoe?
Sure. This is something I actually have a strong interest in as far as shoes. And I actually typically spend, quite a bit of time with my patients on this aspect. One of the biggest things people always ask, well, what is the best shoe? And it's not about what the best shoe is what is the best shoe for you? And, there are a lot of different factors that play into that. So
Yeah.
a good shoe for me is not necessarily a good shoe for you. So kind of breaking that down a little bit in a little bit more detail. First is a good heel counter. And that is the lower back part of a sneaker just above the sole. Typically, we want that to have a stiffer material, and that provides more support and stability. The actual sole of the shoe, I have patients opt for at least a semi-rigid sole. So that means a sneaker or a shoe that does not bend very easily throughout all aspects of the whole sole. The sole should only bend at one place, and that's the ball of the foot. That's the only part of your foot that actually bends. So that's where the shoe should bend. So again, if you're finding the shoe is bending along the whole part of the sole, or I often see it a lot in the middle, that's not a properly constructed sole. So when you're also in a more flexible shoe, it's my opinion that your foot has to do more work in that shoe. So you want the shoe to help you, not to let your foot do all the work inside the shoe. The heel to toe drop, or also called heel drop, is a kind of a sloped height from the back of the heel to the front of the shoe, particularly those with a tight Achilles, calves, or hamstrings, as well as many other foot conditions, benefit from a higher heel drop as it relieves some of the tension on the Achilles tendon. The toe box width and height is also an important factor. Individuals with deformities such as bunions, hammer toes, flat feet, high arches, often benefit from a shoe with a wider width and the edge of the toe box that has more height to that. We want to let the toes sit relaxed and not crunched inside the shoe. The shoe material, individuals with wider feet benefit from materials that are a little bit more flexible or have a little bit more give to the material, as opposed to those such as leather or suede, which is going to create a lot firmer counter pressure against the foot. And then finally is control type. We have a neutral shoe, which are typically better for those with high arches or individuals that have pain to the outside of the foot of the ankle, a stability shoe, which is usually for mild overpronation or a flat foot or fallen arch, and then a motion control, which is for severe overpronation and for maximum control and stability.
Yeah. I mean, it's amazing all the things that go into shoes, yet the majority of patients come in with shoes they got because they liked the color. They liked the style. They didn't take into, or it was a gift. They didn't take into consideration any of those factors that you say when they're bringing it in. So it's fascinating to know that there's so much that goes to it. So what about inserts? Are the drugstore ones worth it, or should people invest in something more?
Typically not. What patients have to understand is companies and products have great marketing techniques designed to capture the consumer using buzzwords in a variety of convincing gimmicks. So I always tell patients, buyer beware. The type of insert a person benefits from is really based on a variety of factors, and that includes the problem that they have, the foot type that they have, and the activity that they do. Rather than waste your money guessing on an insert, just go get evaluated by a foot and ankle surgeon near you. Most patients can be treated with a good over the counter type of insole, but many and some do benefit more from a more customized orthotic, which they can kind of help guide you to.
Yeah, it's important for them to understand, though, that an over-the-counter insert is not just like a cushion. A lot of the ones they find at the drugstore are just pads, and they come in all sorts of varieties. And the simple test I have them do is I say, take it out of the box in the store before you buy it, put it on the shelf, put your finger at the arch, and push down.
Yep.
If it pushes down to the weight of your finger, it's going to do nothing for your body weight. So there are some prefab arch supports, as we call it, that are actually quite good, and people do well, as you say, they can do well with an over the counter type insert. But the other thing I tell patients is that for those who have like a really high arch or a really flat foot, say you don't have an over the counter foot, so an over the counter insert isn't going to work for you, right? So other than arch supports, what is your conservative approach to heel pain?
Shoe gear, as we briefly spoke a bit before. I assess muscle tightness, particularly to the Achilles, the calves, and the hamstrings, and I give stretching handouts to help with that. There's ice, there's anti-inflammatories. We have non-steroidal and steroidal. Non-steroidal anti-inflammatories are things like ibuprofen or Motrin. Some patients can't take anti-inflammatories, and we need to focus on things like Tylenol for a variety of reasons. And sometimes injections can be very helpful to help eliminating pain as well. I don't use that as a uh, primary treatment. I always tell people a steroid injection is not going to solve your problem. It might help with your pain, but it's not going to solve the problem.
Yeah, it's like pulling the string of a lawnmower, I tell patients. It gets the engine started, but doesn't necessarily resolve it. Because there's always three things we need to do. We need to reduce the inflammation, we need to support the arch, and we need to stretch it out. If we do all those things at the same time, generally, it'll go away probably what, 80, 90% of the time, correct?
Yeah, absolutely.
So there's no shortage of internet hacks. What's one home remedy that's actually legit?
Well, I think I'm not sure if you would call it a remedy, but I think stretching. I think the downfall that people have with stretching is they just don't do it correctly. I am a big proponent of longer stretches. I think with individuals that have chronic tightness, 10, 20, 30-second stretches aren't long enough for the muscle receptors to adapt to the stretch. So I'm a proponent of a minimum of two stretches for 2 minutes each. And when individuals are doing both sides. I tell them to do a 2-minute stretch and then rest 15, 30 seconds, and then do the same stretch on the same side before you go to the other side.
Yeah. I've been doing this long enough that I try to have most everybody stretch. It seems like that's kind of the bane of many existence, of many conditions that we see. So I try to get people to kind of stretch while they brush their teeth, or just try to get in a habit of doing that, because we can prevent these things from happening. And when patients come in with like the one-sided heel pain, right? We don't tell them to just stretch the one leg. We tell them to stretch both. And they say, well, why is that so important? It was like, because we don't want you to come back for the same issue on the other side.
Yeah.
Yeah. So how long should someone stick with conservative care before saying, okay, time for a different approach?
Well, I think progress is always the thing to evaluate on that. I generally say anywhere from kind of 1 to 3 months, depending on the condition, the treatment, and other social factors such as activity, work, sports, and other care needs that may need to be provided. But I typically change treatments after 1 to 2 months unless the patient is experiencing positive improvement. If it plateaus or worsens, then treatment needs to change. However, if I see patients back in a month and they tell me they are 50% better, but it's also evaluating, well, what has been the progress of that 50%? If at 1 week after the visit, they were at 50%. In the last 3 weeks, they haven't improved at all. Then to me, that's more of a concern as opposed to, well, I'm 50%, but each week I have gotten a little bit better. That changes my approach to how I'm going to consider a new path.
Yeah, I think the evidence says 6 to 12 months of failed conservative care is what you give it, right?
Sure. And I say when sticking with conservative care, and when I say 1 to 3 months, I say not from moving to surgery. It's moving to an alternate, potentially alternate forms of conservative care that we haven't already introduced.
Gotcha. Sometimes, though, we can't avoid surgery. In our final episode in our Heal Pain mini series, Dr. Kelly and I will be discussing what most people want to avoid: surgery, and the when, why, and how, and the recovery for it. So, thank you, Dr. Kelly, and thank you for listening. You've been listening to the Foot Health Facts podcast. For more information on today's topic or any foot and ankle concern, head over to foothealthfacts.org. On behalf of the college, I'm Dr. Matthew Dairman. Thanks for joining us today. If you enjoyed this episode, don't forget to like, subscribe, and share it with someone you care about. Together, we'll keep everyone moving forward one step and one topic at a time.